Hey, everybody. Alex and I today are going to talk about a study from 2017. It is called The Impact of a Value-Based Insurance Design for Physical Therapy to Treat Back Pain on Care, Utilization, and Cost. We're going to link this in the show notes so you can take a look at it yourself. So, just a quick summary of the article before we get into it. The purpose of the study was to assess the impact of a value-based insurance design that provided enhanced access to physical therapy for treatment of back pain on care utilization patterns and cost of care. The intervention they called the quote PT bundle was designed to reduce financial barriers to PT by offering up to 5 visits for a single one-time copay, which was comparable to the cost of a single visit copay. And that could be renewed again as needed once for another 5 visits for another 5-visit bundle. So it was a retrospective analysis of claims data using a difference in difference approach for Geisinger Health Plan members. So it's a regional health plan in central Pennsylvania, and it is the Geisinger Health System that administers this Geisinger Health Plan. So these were adult members 18 years and older with employer-sponsored health plans. The diagnosis of back pain had to be present, and they were authorized for PT. The study period was January of 2013 to October of 2014. So the sample was 4,390 unique members. 197 of those members were offered the PT bundle, and 2193 were offered the standard per visit copay. That was the comparison group. The observation was average 17.4 months per member. So the member analysis was a member fixed effect linear regression model to compare the PT bundle cohort against contemporaneous comparison cohort that received PT under the standard per visit copay arrangement. So the outcomes measures were PT visit rates, were ED rates, were primary care physician and specialist rates, inpatient admissions, injection rates, and total medical allowed costs or per member per month. So just to touch on a few of the results, you can take a look at the study for the rest. At first, PT visit rates nearly doubled, which is common in something that is new and that you might expect when offered, someone is going to take you up on. And then in months 4 to 6, they were still elevated, but much less significantly. And then after 9 months, PT utilization fell 53% below expected levels. Emergency department visits, they saw a 29 to 35% reduction in ED visits during the 4 to 9 month period after the PT was pre-authorized. In months 4 to 6, it was a 28.9% reduction. And in months 7 to 9, a 34.9% reduction. A couple of other things. After 9 months, the reduction in specialist visits was 35.1%. Injections was about an 85% reduction after 9 months. They did not see a significant impact on inpatient admissions. So, general conclusion, the PT bundle led to a change in treatment patterns for back pain that aligned more closely with recommended guidelines, emphasizing conservative management PT as first-line treatment. And it was associated with sustained reductions in potentially avoidable care. Again, to take a look at all the rest of the conclusions, take a look at the study. Hey, Alex, we're back for episode 24. So soon. We just had to see each other again.
Let's do it. Let's get the Friday started right there.
So I reached out to Alex today because I saw a post that he put up about an article from it was 9 years ago, but it might as well have been yesterday because it's just as relevant. And so we're going to talk about that for a little bit. And essentially, it is no surprise to our listeners, it is about value-based care, but it has real implications for you. And we want you to believe in it and be excited for it and understand that it has the potential to improve your life as a therapist, the lives of your patients. So this gives a great example of a study that was done at Geisinger, and Geisinger is a big medical center in Pennsylvania. And so I am going to let Alex tell you about that, about the study and what they found, and then we'll have a little conversation about it. Take it away.
Perfect. Thanks, Dana. No, thank you. Thank you for that. And I think it's a wonderful opportunity for us to introduce our audience to literature that actually shows a step-by-step guide on how systems can absorb and adapt these value-based processes to actually make a difference and to make an impact in patients' lives. So the study is from 2017 in a Journal of Pain Research, and the study was authored by Mine, Grabowski, Allison, Fisher, and Bulger. Title of the study is Impact of Value-Based Insurance Design for Physical Therapy to Treat Back Pain on Care Utilization and Cost. So the important factors here to notice is that it is a large hospital system that has chosen to use physical therapists as a first point of contact for this very common cost prohibitive diagnosis. And they tracked these individuals over time, looked into the healthcare utilization parameters, looked into the clinical parameters, and identified the value statement. So this is, I guess, our how-to bundle on how to use these systems to actually make a difference.
Yeah.
So the first thing we should really look into is that value-based system design. And one of them is what we spoke about before, probably now close to a year before, which is a path dependence, right? Now, path dependence is that a traditional model is path dependent on an individual pursuing care entering the system from this very expensive but ineffective method where you do your general practitioner specialists tests, procedures, etc. And so you break this path dependence by creating a design where a PT is the first point of contact and you bundle the visits. So the Geisinger bundled 5 PT visits into this pattern. So you will notice that it's not excessive. They didn't bundle 25 visits. They didn't say that you need a year of physical therapy, but really 5 visits is like, if you look into some of the other studies, show that the highest point of clinical efficacy in a musculoskeletal encounter is like visit 1 through visit 4. That's when you get the biggest bang for the buck. And then there's a law of diminishing returns. So you just
That's a
don't
good
get.
point, though, to bring
Yeah,
up because I don't think everybody realizes that.
yeah. So like the PEP dependent, like you need that you need initial visit to identify the problem. You need some reinforcement, and I think it takes a couple of visits to reinforce changes in behavior because a lot of musculoskeletal problems, back pain included, is behavior driven. It's the things you do, and even though most patients pursue care for symptom elevation or symptom reduction, most clinicians know that the true value and the true clinical efficacy is through this behavior change. So the goal of the study was, or the goal of the system was to reduce financial barriers and encourage early concordant care for treatment of lower back pain. So and that's also something important to notice is that it's not just any care. Like you can't just throw a heating pad in a modality an individual expect a difference. It has to be a clinical guideline concordant or at least evidence-based concordant. And that's something we discussed last episode where there's a large spectrum of what would be considered concordant. Like movement systems are variable, your philosophies are variable, but there's high value care, which sometimes is hands-on care, exercise-based care, belief and education-based care, and then there's low value care, which is like modalities and like fear mongering, catastrophization. So I think that like with this, I will pause and I'll let you just comment on it a little bit.
No, I think it's a great reminder, some of the simpler points that a lot of the impact that we have is on helping create behavior change. It's also our secret sauce, right? It's not something that our physician partners are necessarily as good at, and they'll generally readily admit that. But the physical and occupational therapists and the behavioral health therapists, those that our job is to help create behavior change through a bunch of different ways that we work with people. A lot of that value is created in the first couple of visits. Now, does that mean that, a week or two later, another follow up wouldn't also be valuable? The point is, even a couple of visits can make potentially as much of a difference sometimes as what we imagine we need. And just breaking that idea that we need to be doing a lot of visits or otherwise we're not giving patients what they quote deserve or what they quote need. And we really need to think carefully about prognosis, patient need, specific treatment plans. This is calling that out in a different
And
way.
that's yeah, and it's so important for us as an industry to get away from saying it's just exercise, it's just
Right.
manual therapy, right? That's your secret sauce. Like it's not, it's just a scalpel, but it's a scalpel that gets things done. It's just a surgical robot, but it gets it done. It's just a chisel, right? Like it's not just exercise because in a skilled hands, exercise becomes a tool of progress and a tool of clinical improvement. Same goes for manual therapy and any other clinical modalities. So it's the encounter with a treatment, concordant and guideline-based treatment that's important. So the first important caveat to look into is the utilization parameters. And so here we see that there was a marked increase in physical therapy utilization, understandably, in the first 3 months of care. But then after 9 months, physical therapy utilization fell below the benchmark, below the typical levels of utilization. So what
You
you
mean
see,
population level utilization, though.
oh,
You
yeah,
don't mean per patient that was treated per the population, right?
yeah. So
Yeah.
you can expect like the systems monitor physical therapy utilization year after year, right? So yearly utilization of physical therapy based on a population per user per month or per user per year or whatever. And so you had a slightly higher uptick in utilization in the first 3 months because people probably saw value in continuing care beyond 5 visits, especially if they had suboptimal or incomplete return or recovery. Now, but then at 9 months, you actually had lower levels of physical utilization because that shows, that marks that there was a higher level of recovery compared to the traditional model where people would pursue general medical care and then follow physical therapy. And then they almost, general medical care uses physical therapy as a babysitter, or they park patients in physical therapy. And that's where you see the overutilization, where medical community doesn't know what to do with the patient and it's a persistent or chronic or difficult case. They just park you for the rest of your life in physical therapy. Go get some more physical therapy. And that's unfortunate, right? Because it reduces clinical efficacy, because as a therapist, you also know these patients. They've been in your clinic for months, and they're just like, they know the routine, they know what to do. They're like, it's a nice social hour, but it's not really clinically advantageous because they're being parked. The medical system is exhausted, and they're just using physical therapy as a scapegoat, as a lowest common denominator. But that's not the right way to use physical therapy. The right way to use physical therapy is to reduce uncertainty, to educate, to create a plan of care, and then to execute plan of care. And the evidence shows after 9 months, there was actually low utilization of physical therapy services compared to the general community, general population. So I think it's important to notice. And when you're communicating with physician and other stakeholders, is that look at a bigger picture. Look at the overutilization over a year. Don't look into week to week or month to month utilization. Those are not accurate economic benchmarks. So I'll pause here.
Yeah, no, I great points. And just, worth pointing out that there's good utilization and there's maybe not so good or avoidable utilization. And we really think in the value-based care world about these in two different buckets. There's not enough utilization of some services, and I'm talking about at the population level. And then there is an overutilization of services because of the underutilization of services that can prevent that overutilization. So when patients are getting enough upstream care, right, easy access to the care that they need for musculoskeletal or behavioral health or primary care, preventative care, et cetera, then they end up using more downstream care. So we want to see more at the population level. We want to see more patients seek physical therapy. We know that there's huge numbers that we should be the primary point of musculoskeletal care contact, and we're not. So we want to see that number grow. But generally speaking, it's common to overutilize the number of actual visits. So physical therapy utilization should go up, like primary care utilization should go up if we want to prevent the higher cost medical specialty, MRIs and imaging, emergency room visits. We want more of us, but we have to be smart about how we interact and at what cadence and in what ways. Is it telehealth? Is it in person? Is it RTM? Whatever. So,
Absolutely, communication, right? Like, and now we'll look into the overall healthcare utilization from these individuals that were thrust into this new model. And one factor that jumps at you is that there was a 35% reduction in emergency department visits compared to the general population. And think of it, why? Like, what's scarier than having this profound impact, pain impact on your life that is covered with a high degree of uncertainty? You don't know why it hurts. You just know it hurts a lot, and you know your mobility is compromised. And the first thing that comes to your mind is we all catastrophize when something happens. We don't know, which is this going to lead to paralysis? Is this cancer? Is this something that's going to be drastic, right? So that the whole runaway train of catastrophization occurs when you don't know how to manage your symptoms. And the first encounter of physical therapist will help you to manage your symptoms. So it may not cure your pain, it may not cure your disability, but it definitely gives you self-management tools. When a symptom occurs, you do B, C, and D. And in absence of physical therapy, these people are still looking at the void. There's void of source of truth. They go online, they ask their friends, they ask their neighbors, and then friends and neighbors will usually, like that negativity bias. That's one of the heuristics. They'll only tell you the worst case ever. Like, oh, I had an uncle whose back was hurting, and then he got hit by a train, right? So you have these, but when you encounter physical therapy, physical therapist becomes a source of truth, and that leads to reduction in emergency department visit, and also 85% reduction in injections, and also a change in other healthcare utilization parameters. Because I know that the back hurts. You normalize the ache, and the part of physical therapist's job is not to cure, but also just to normalize these symptoms. Pain is normal. Sometimes pain has a high level of impact. But as long as we all know the red flags for back pain, the studies about back pain, as long as you're not showing typical signs of cardiac quietness syndrome, as long as you're not having significant changes in your toileting behavior, as long as you check off all the red flags, you just have a large spectrum of what is normal. There's a low impact pain and high impact pain. Both are normal. Like you can have a lot of pain and still be a normal human being. And that's what early physical therapy does, is it normalizes your discomfort, it normalizes your disability. And then further looking into a physician utilization, there was an interesting fact that there was a reduction in primary care physician visits, but there was an increase in specialist visit. And the comment from the article is that the suggestion is that potentially the further reduction in PAP dependence is to have a direct flow of emergency department to physical therapy, to circumvent medical services altogether, so not to have liaison in between that will reduce the specialist visit. And there's a lot of good work by Rebecca Griffith in Colorado, like ER doc, right? So she's doing just that. She's a physical therapist. She's a PT specialist in an emergency department that has developed this entire system of being a PT in emergency room that actually oversees emergent visits that has shown excellent results. So, like, I encourage all of our audience to look her up too and to see what she's doing.
Yeah, we have to have her on to tell us about this because, again, anywhere you can access care, you wanna have a physical therapist there as the potential first line provider,
Yeah.
right? And my question as you're talking, Alex, was, do you know or did the article point out if members I'm assuming it was Geisinger's health plan, were members told about this new benefit? So what was the precipitating event behind more patients actually eventually seeking therapy?
I believe that they were given a choice, and the sample was then once they have chosen, they were restricted from other services. Like there was a cutoff date when they had to sign up for the service.
Okay, okay. That's interesting
Yeah. So and then I would have to go deeper into it, but
because that's one of the issues, right? Is the public's
mhm, yeah.
perception and who tells them to do something and what they think is the way I should seek medical care and to whom I go first. But if it's presented in a different way because of something like this, that's gonna certainly impact,
And
who
then you look
seeks
into the
care and
choice
why.
architecture, right? Like,
Say
so
it
the
again?
defaults, choice architecture and
Right.
defaults. If a system creates a default that physical therapist is just your primary point of contact, and the way you explain this, the story behind it is that our studies have shown that people have better outcomes. There's just you are priming a more favorable clinical outcome based on just even explanation and the storytelling, versus if the system says that you have to exhaust physical therapy before you get to see one of our physicians,
Ugh.
then it's a negative priming effect. You're going to have an individual that does what they can to fail physical therapy encounter, and even if they have a favorable clinical outcome, they're still going to pursue medical care. And you know what I'm talking about, Dana.
It also makes the profession look, like, diminutized. To say that we're a barrier to the care that they think they deserve, right? It's incredibly frustrating to be in that position. We're like middlemen. And we know that that's what the patients are thinking. I used to and that's if I believed that the patient did not need surgery or that it was possible that through the physical therapy services that they may have a different outcome and not choose surgery, I would really try to make sure I presented that equal case
And
because
yeah,
it just shouldn't be a given unless they actually need it. And if they actually need it, then is there a specific reason that they're getting PT first?
I think you have a self-selection almost that you certainly see when the surgery is necessary, the surgeons will find their patients, and it's if the things are emergent, if the problem is emergent, if the patient is in need of higher level clinical care. They'll find it. This article shows that there was a no increase in high cost medical drivers, right? So no surgery, no procedural interventions. There's a little caveat, I guess we should add, that there was a couple of really high level studies that have come out in the last couple of years have shown when surgery does work better than non-surgical care, and that's for an acute sequestrated disc. So like,
Yeah.
and there's two things
Ruptured,
that you
totally
mentioned, right?
ruptured. Yeah.
Disc rupture, like the microdiscectomy was shown to be superior
Oh, yeah.
to non-surgical care in acute cases where like microdiscectomy is relatively well tolerated, minimally invasive surgery, and when done right in a proper amount of timing, it actually saved significant amount of pain and disability and healthcare cost of these individuals. So like it's not always PT first, right? Like sometimes surgery
No, of
first.
course not.
But no one to have surgery. So if you have this acute lancinating pain down your leg, and if you have paresis and foot drop, and you're failing to show up to work for the second week in a row because of your ruptured disc, discectomy is a proper choice of care. If, however, your symptoms are stable, if the level of pain impact is relatively moderate, and if you're able to cope with it, then physical therapy, right? Like that's the clinical decision tree that you have to follow. We need to then like go deeper into this style, and that is physical therapy an end-all solution to, like, is the emergency department the proper feeder for physical therapists? Are physical therapists better off going to primary care physicians and signing this pact that when you have these are clinical guidelines for lower back pain care based on finding A, B, and C, right? And that's your decision tree. So are we better off having these decision algorithms that we can present to our medical partners and physician partners, who then can use them to identify, I have a patient in my room right now, they present with the symptoms that are more applicable to you, and ultimately, not to be a nihilist, but do physicians really care about this decision tree, or is it still going to be this defensive medicine that now just go see the specialist, let's get an MRI to see what's going on in your back? So that would be my question to you. Like, do you think that extra education, extra aids, health aids that educate physicians, will it help, or is it kind of, are we defeated?
I don't think we're defeated. It just everything is dependent on incentives. To go back a sec though, to make sure I'm answering this the right way. In this case, tell me how what was the primary care doc told to were they told to say something specifically like,
It was physician office, a primary care physician that referred to physical therapy, like for this path. Like,
and
so,
they were told that they were part of a study, then they were going to look at the efficacy of PT.
and it was a model, like a clinical, so they had to opt in or opt out of this model.
Okay. Why were the physicians participating, or was it just that the health system told them that they were gonna be participating in this?
It's an excellent question. I think that there was a reduction in copay, so there was a financial incentive for the patient.
Okay.
So they dangled that like a reduction in copay if you go see like that 5 PT visit bundle.
I
And I can give
gotcha.
you like with the real world, like, so working with one of the in-home outpatient physical therapy providers, there's enough payers that have done this to encourage, to nudge people into pursuing physical therapy first, where like Devoted Health and PAM Health,
Mhm.
well, have all created these different pathways and models where they would write off a copay, where they would write off a portion of the deductible if you were to pursue physical therapy first, especially if you were identified as a high risk for future joint arthroplasty or high risk for downstream utilization. So, and then on our side as a clinician, you can create a risk stratification tool that looks into demographic information, that looks into prior utilization parameters, that looks into that psychosocial parameters to really roll out these patients into your pathway. So, like, that's just a little bit of.
Yeah. And this is such a great thing we're bringing up here because that flexibility in being able to, as a health plan, depending on if you're a Medicare plan or you're, CMS themselves or you're a commercial plan, that's going to be the determining factor as to whether or not you can waive a copay. And that is one of the things that, in Medicare fee for service, which we're not talking about right now, but in Medicare fee for service, it takes innovation center models to allow getting around the statute that you cannot waive copays. Now, when you're in a commercial plan, this is probably the Geisinger Health Plan itself. They can choose whatever structure they want, and they have a lot of flexibility. And that flexibility that's the exact reason why the Innovation Center has all this flexibility to try things that are done in other environments that they cannot do in Medicare because of statute as it's written. If it's proven, then they can change statute. They have to prove it in the model to change it in the statute. But a commercial plan being able to say, hey, we're going to try this thing, but we're going to either reduce or waive the copay if you choose this option. Well, that's amazing. That's innovation in and of itself. They can just do what they want because they're their own health plan.
But who talks to these health plans, right? So like I guess that becomes more of a cycle, like a positive or a negative feedback loop, or if the health plan sees success. And I guess this would be a good question for our follow-up, even the conversation. But why this article is 9 years old? Geisinger is covering 500,000 lives, so like it's a plan that covers a significant amount of population, and the article has been able to show longitudinal positive economic effect. Why do we not see this more frequently? Why do we not see other systems like Advocate Healthcare or any other healthcare systems that look into this and say, like, look, we'll save money, provide better outcomes, and ultimately help patients? Why is it not
Right.
being
Well,
looked at
first, I
commercially?
want to see, I think some of them are starting to, but more than anything, sometimes organizations don't want to do something for a population if they can't do it for all because of the statutory limitations in Medicare. So if they have a heavy Medicare population, they may be less interested. It's when you have a health system that has its own health plan is where you're going to see a lot of that innovation. And interestingly, Geisinger did one of the most famous studies about this was about providing all of the food for an entire family, and it wasn't one family, it was a host of families, for all of their diabetic patients whose A1C was above 8. They provided for 18 months all of the groceries for the entire family for the entire 18 months. And they saw, and it cost, I don't know, 20 or $30,000 in total per patient. It reduced costs by an average. Well, take a guess. What do you think the average cost was in reduction of healthcare utilization per patient?
Monetary or percentage?
Monetary.
Oh, $75,000.
And 40 or $50,000.
Well, that goes to show you the externalities, right? Like, so nutrition, sleep, quality of life, social determinants of health, like how all of these parameters, when
Fed the
managed.
entire family, right? And that alone enforcing the choice of, I'm sure they weren't perfect, right? But just having the right choices of food and the support that went along with it. Why isn't that everywhere? Innovation in healthcare is painfully difficult, painfully difficult.
So there's like there's an interesting economic phenomenon, right? Like which is that like unpaid care work, where like if you look into diabetes and if you look into that as a social phenomenon, not just an endocrine phenomena, there's a significant amount of impact that has an entire family of taking care of diabetics. Like I know on a personal level, but it's like diabetes is a nasty disease that requires significant amount of support from everyone in the family. So if it's your parent, the children have to drive parents to their visits. There's so many procedures. So if you can reduce the impact of diabetes on that individual and the family, right? Like how much is it going to have an effect, like an economic effect? And I bet you if Geisinger like actually did a study and looked into the impact on employability and presenteeism of the family members that don't have diabetes, they would find a lot more externalities, right? Like
Mhm.
it's the free rider problem. Like we can discuss the free rider problem, but it's that public good. It's that when you benefit from something that is done to somebody else, like the entire family benefits because that individual with diabetes actually has nutrition that is stabilized and normalized. And a lot of these problems are modifiable risk factors. Like Geisinger took a modifiable risk factor and took control of it, reduced the intake of substances that have a negative impact on A1C levels. And here you go. So
But
Dana,
it's not traditional medical care, right? It's not medicine. It's not an injection. It's food as medicine. And that's not the first and only time we're going to see that. This is becoming a more common, especially
health
with the
care, right?
D-SNP plans and those, the plans for some of the sickest Medicare beneficiaries and Medicare Advantage. They're adding that benefit little by little. But you're gonna start seeing this as what's medical care and what are non-medical drivers of health, like food, that have a vast, vast impact that no other medicine could have how else are you gonna reduce a diabetic's healthcare costs in 18 months by $250,000 per person? Not easily.
I think it's really important to understand and appreciate these things have been tried, right? Like, and there's so many modifiable factors, and there's so many different ways you can make an impact. But to go back to the study, this is the study that shows clearly that the systems work when you create economic incentives, when you create general incentives, and you create path dependence, where physical therapy is a primary care organization or entity to take care of these musculoskeletal problems. Everybody wins. The system wins, the patients win, and the therapists get their volume of care. So,
And
yeah,
maybe that's the big takeaway here is it's a theme. Value-based care shifts the incentives, and behavior change is required to change how care is delivered, and changing how care is delivered is what's gonna give you different outcomes. It's all the same story that, just told different ways. I love that this study, did something quite unique, just, offered a different way of approaching a condition that was presented to patients, and then we follow along and see what happens, and the incentive was the reduction in their copay. So look, you give an incentive to a patient, they say, "Okay, look, that'll change my behavior." It's start there, it's that simple. We can't really argue with a lot of the clever innovations that this gave an incentive to who do we need to incentivize here? The patient.
we have to
Right?
kiss things, right? We have to keep it simple.
That's right.
Kissing things makes a difference. Now, Dana, thank you for this. Hopefully, this shortened episode will be of value to anyone who's listening. And stay tuned for more. So,
Yeah. So great. Happy weekend. Great to see you, Alex.
good to see
Bye.
you. Bye, guys.
Okay, so couple of practical applications for your practice as you think about the article that we just talked about. First, partner with the right organizations. So think about partnerships with integrated health system or organizations participating in value-based care models where PT first approaches can be implemented. Think about developing risk stratification protocols. They help to determine which patients will benefit most from early PT intervention. Really meticulously document outcomes of your care. So you don't just want to track clinical outcomes, but cost avoidances, surgeries prevented, imaging reduced, specialist visits avoided, which builds your value proposition. That can sometimes mean working with a data vendor. So maybe and then engaging with payers, approach commercial health plans with proposals for PT first pilots that include things like copay waivers or incentives for high risk populations. You can use this article as an example of what can work and learnings. Educate referring providers. So, just sharing this research with physicians and administrators can help build support for changing the referral pathways and establishing PT as first line care. And then marketing even directly to consumers. In states, you know, there's direct access to some degree in every state at this point for PT. You want to emphasize that the clinical benefits, potential cost savings, and kind of think about the overall outcomes that came from structuring incentives. And the study really remains relevant a decade later because it demonstrates that when incentives align, so incentives for patients, providers, and payers, PT first models work. The challenge is not improving the concept, but there's regulatory and organizational barriers or just complexities that sometimes make it hard to have widespread implementation. It takes, momentum and trying things and focusing on it to really have a long-term change seen.